At the 8th Annual Oncology Practice Summit, Dr. Jorge Cortes gave us an update on prognostic factors in chronic lymphocytic leukemia.
For our practitioners, and it comes up in my practice a lot, new CLL patients diagnosed, and we have a number of prognostic markers which we can send. So on or off clinical trials, so for the private practice office or for someone wanting to refer to you, what are the prognostic markers that you recommend we get, and how do you use them?
Yeah, that's a good question, because as our knowledge evolves, we come up every time with new things, and then how do we integrate them and which ones are of value clinically? I would say that there's two that I find very useful. One that has been there for a long time and it's still very valuable, which is beta-2 microglobulin. That's an easy one to get. And it continues holding its value as a prognosticator. So I do get that always on my patients, and it helps me, for one, be able to give the patient a little bit of information about what we can expect beyond what we get just from the regular RAI.
Is that renally excreted? So in our older population, that might have to be factored in?
That is correct. Function? It is renally excreted, so you have to adjust that, and you know your renal function and adjust by that. The other one, I think, of the newer ones, I think, to me, probably the most relevant, the one that I follow the most, is the cytogenetic abnormalities. So a FISH, where you look specifically at abnormalities in chromosomes 13, 12, 11, 17, that's very relevant. It is not very common to find a patient with abnormalities in chromosome 17 at diagnosis.
But that can evolve.
It can evolve, and that tells you that patient has a very poor prognosis. Of course, you put in everything else, their age and other factors, and then decide what's the best outcome for the patient. If you have somebody with a 13 PP abnormality, those patients are going to do very well. So that you factor that. I think that with those chromosomal abnormalities, you can make, again, putting that together with the age and comorbidities and other factors of the patient, it can help you decide what's the best approach for a patient. Certainly, immunoglobulin gene rearrangement, CD38, SAP70, those are important, they're useful. But number one, they correlate with each other a lot. And number two, I think that then it starts getting a little too complex for just a community practice.
And these are, I think, as I'm listening to you, these are all readily available tests we can order in the community.
That is correct, they are.